Hello. In the next 15 minutes or so, I'm going to talk to you about the economics of continuous kidney replacement therapy. Before we get into the economics, a little interesting tidbit from the history. The way continuous renal replacement therapy started was when Dr. Kramer and colleagues accidentally introduced a vascular catheter into femoral artery instead of femoral vein, and recognized that he was able to actually produce a pressure head which allowed blood to be filtered through a hemofilter and an ultrafiltrate to be generated. And this was the diagram that he showed in his publication in a German journal. Subsequently, Dr. Robert Uldahl from Canada actually modified this by introducing a blood pump, which you can see here, allowing continuous veno-venous hemofiltration to be made possible. Since then, a lot of modifications have been made to the simple technique, which was the first one that we used many, many years ago when I was a fellow. And now you have complex CRRT systems. You have a hemofilter with tubings. You have multiple solutions. You use sophisticated anticoagulation. You, of course, need to have catheters for vascular access. We use blood warmers, etc. This is from just one particular system from one company. And then you have in additional add-ons, you have medical records, and you can upload it on the cloud, and you can have a card that can be given to the patient, which he can carry around or she can carry around. You have had variations on the filters, which are now used for specific purposes, developed by different companies, Torre, Cytosorb, and Oxiris by Baxter, and they're all used for sepsis, for removal of specific cytokines, and are promoted aggressively by pharmaceutical companies and are used in many clinical settings. But coming back to the basics, I think it's safe to say that for management of patients with acute kidney injury, there is no clear evidence demonstrating the superiority of continuous renal replacement therapy in survival rate to that of intermittent renal replacement therapy. However, we should also note that continuous renal replacement therapy is appropriate for specific group of patients and where a personalized appropriate approach to treatment is needed, and we'll come back to that a little later. Another important question which will influence decision and calculation of cost of treatment is, do different extracorporeal therapies lead to differential rates of long-term dialysis dependence? That's an interesting one. And here is data that was published in a meta-analysis some years ago. And this meta-analysis looked at summary of evidence from randomized clinical trials and observational studies. And this forest plot shows data only from randomized clinical trials. And here you can see that the summary evidence, which is shown here in the diamond, fails to cross the line, which would indicate whether it is clearly superior or clearly in one treatment is clearly superior compared to the other. CRRT being on the right side of this line, but the point estimate, as you can see, indicates some degree of superiority for continuous renal replacement therapy. However, when the same authors looked at observational trials, the observational trials seem to suggest a clear superiority for continuous renal replacement therapy so far as long-term dialysis dependence was concerned. And they said observational studies suggest that continuous renal replacement therapies are superior to intermittent renal replacement therapies such as hemodialysis or SLED in reducing long-term dialysis dependence. That's important because people who require dialysis long-term end up costing the system a lot more. So I'm going to show you the results of some cost effectivity or economics of dialysis dependence following kidney replacement therapy for critically ill acute kidney injury patient. This is again uh, analysis which was done using this Markov model, and the decision analysis tree that they used was looking at patients with acute kidney injury in the ICU, and they model it in the following way. The patient could receive either continuous kidney renal replacement therapy or intermittent renal replacement therapy, and the patients could switch from continuous renal replacement therapy to intermittent renal replacement therapy, and the patient could either die, the patient could recover and become dialysis independent, or the patient could become dialysis dependent. And of course, they will be discharged from hospital. And this was their modeling based on the data. They used observational study data, the meta-analysis that I showed you before, and they used other study data. And what they actually modeled was that they found that if a patient had received intermittent renal replacement therapy, which is hemodialysis or SLED, as the initial form of renal replacement therapy, their likelihood of being dialysis dependent, shown in the solid black line, was higher compared to if they had received continuous renal replacement therapy, shown here in the lighter gray line, which is lower in this particular graph. And as a result, they looked at the 5-year cost effectiveness analysis of initial CRRT strategy versus initial intermittent renal replacement therapy strategy. And you can see the health outcomes, the costs, and then the cost effectivity analysis. So the health outcomes are modeled as life years gained, continuous renal replacement therapy first, and intermittent renal replacement therapy first. You can see life years gained, no difference between the two. Quality adjusted life years, again, some advantage for continuous renal replacement therapy. You can see the costs for renal replacement therapy. Clearly, continuous renal replacement therapy cost more. Dialysis independence, some difference in the cost, but not a whole lot. But dialysis dependence, you can see that intermittent renal replacement therapy starts to cost more. And when you take the total intermittent renal replacement therapy costs more. And then they go on to do cost effectiveness analysis, in which they divide the cost with the life years gained. And here you can see cost life years gained and cost quality adjusted life years gained. You can see that CRRT is better than intermittent renal replacement therapy. And then the final parameter they look at is the incremental cost effectivity ratio, continuous renal replacement therapy versus intermittent renal replacement therapy. And they arrived at this figure of minus $116,000 plus dollars. And they summarize this by saying that the CRRT dominates. This is the economist language. Then they went on to look at the 5-year cumulative cost. And so if you model it in terms of the number of days after kidney replacement therapy initiation, initially CRRT therapy costs are obviously higher, but 2 years out, continuous renal replacement therapy costs come down. And in the long term, continuous renal replacement therapy first strategy costs less to the system, because these people cost less because they are less likely to be on long-term dialysis. And the final 5-year cumulative total cost of dialysis dependence obviously is much less, according to their analysis, if the patient starts with continuous renal replacement therapy. And then they provide what they call the tornado plot. And this shows that most of the difference between the two modalities is actually accounted for by the risk of dialysis dependence and dialysis independence health utility costs. So that's just one analysis. Now, just to show that a lot of these results actually are dependent on the way you approach it and on the healthcare system. So here is the second analysis, which was conducted by researchers from Canada, from Drs. Scott Flarenbach and colleagues from the University of Alberta, Calgary, etc., in the Alberta Kidney Disease Network. And this was the model that they used. They also chose initial CRRT and initial intermittent hemodialysis model. Whether the patient survives, no, yes. If the patient survives, does the renal recovery take place? Yes, no. If the patient is discharged from hospital, if the patient is alive or dead, on dialysis, or remains dialysis free. And they took a number of assumptions and they used this for what is called the Monte Carlo simulation, which is the method which was used in the previous study as well. And they looked at the relative risks of in-hospital mortality, CRRT versus intermittent hemodialysis, renal recovery, again, between the two modalities, in-hospital mortality, and then computed probabilities of in-hospital mortality risk, renal recovery in hospital, probability of renal recovery among survivor on chronic dialysis, probability of need for chronic dialysis amongst those who survived but were not on dialysis at discharged, annual mortality for hospital survivors on dialysis, and annual mortality risks for survivors who had shown renal recovery. And then they computed quality of life scores for people who were on dialysis and who were alive and had shown renal recovery. And you can see the base case values that they computed in these various scenarios. And they also had a range for sensitivity analysis because they wanted to see whether these analysis for base case values also held up during the various sensitivity analysis. And this is what they found. So for the base case analysis, in taking this was the scenario: CRRT versus intermittent hemodialysis. CRRT cost higher, as you can imagine, and the incremental cost of CRRT was $3,679 dollars, and effectiveness, which is quality adjusted life years, CRRT was higher. For hemodialysis, you can see here, and incremental cost for quality adjusted life years gained, just for the base case scenario, CRRT dominated. But then they looked at the relative risk mortality for CRRT versus intermittent hemodialysis. And here you can see the numbers: CRRT cost and incremental cost for CRRT was greater. And then here you can see the incremental cost per quality adjusted life years was 39,000 Canadian dollars. So you have to spend $39,000 more to gain one quality adjusted life years. And here, what is important is to introduce one more concept. What is the accepted threshold for amount of money that the society is willing to spend on gaining this quality adjusted life years? And that will vary from country to country. One country may vary, or one society may vary or value one quality adjusted life year much more compared to another society because of the circumstances, socioeconomic circumstances, etc., that prevail in that particular society. And similarly, you can see the relative risk of mortality for CRRT versus intermittent hemodialysis. And you can see that the relative risk of mortality of CRRT versus intermittent hemodialysis, again, exhibited here in terms of incremental effectiveness. Quality adjusted life years of CRRT is minus 0.54, and here the incremental cost per quality adjusted life years gained is 20,000 intermittent hemodialysis compared to CRRT. Relative risk of renal recovery for CRRT versus intermittent hemodialysis, relative risk of renal recovery for CRRT versus intermittent hemodialysis. And you can see that intermittent hemodialysis dominated. So these authors actually concluded that CRRT was not cost effective for managing patients with acute kidney injury, all patients with acute kidney injury in ICUs. And then here was this third cost effectivity analysis conducted in Europe, and they looked at cost-effective analysis. They compared CRRT versus conservative therapy, intermittent renal replacement therapy versus conservative therapy, and then finally CRRT versus intermittent renal replacement therapy. And they found that, to cut a long story short, that the incremental cost-effectivity ratio was more than 100,000 euros per quality adjusted life years gained. So what it means is that if you choose to treat all patients with with continuous renal replacement therapy compared to if you treat all patients with intermittent renal replacement therapies, you have to spend 100,000 euros more to gain one quality adjusted life years. And then the final decision is the society prepared to spend that much money? Then what they did is they conducted thousands of cost effectiveness simulations, and in all the simulations, they found more or less the same result, that the absolute cost of CRRT was much greater compared to conservative therapy, of course, which is the cheapest, and intermittent renal replacement therapy, which is in the middle. So what is the summary of all of these findings? And those who play chess will recognize the situation, which is one of stalemate. But what does it mean? We don't make bedside clinical decisions whether to put a patient on intermittent or continuous renal replacement therapy by looking at cost effectivity analysis results. We make these decisions based on the clinical condition of the patient. And this is a process known as shared decision making, in which we look at multiple factors. We look at quality of evidence, we look at feasibility, health system considerations. Of course, financial considerations do come into picture, but they are just one of them. We look at the individual level factors, we look at population level factors, we look at social level factors. But in the end, we look at balance of health benefits and harm, and we discuss it with the patient, we discuss it with the health systems, we discuss with those who are going to pay for treatment. And then eventually we have to realize that we need to go back to look at what are the goals of treatment, specifically what are the goals of CRRT. And they're shown here, and I don't need to recount you to them. And we need to see whether any of these goals are important in the context of any given patient. And then in the end, we have to also keep into account other considerations. Are we able to give CRRT if we choose to do so in the right dose? Do we have the right vascular access? Are we able to give optimal anticoagulation? Will we be able to generate optimal filtration fraction to avoid filter performance degradation? Will we be able to initiate and terminate CRRT in the proper timing? And do we have access to the specialized filters that we need? So a number of these factors will come into our decision-making process. And I think while we do want to do cost effectivity analysis, they are not the only factors that help us make our decision. I'm going to stop here and we'll be happy to take any questions.